You start now if you're going.
So my name is Dr. Wilfredo Rivera, licensed psychologist here in the state of Florida and part of the NBI team. I have already been working at NBI for the past 10 years and a half, basically.
Mhm.
I started as a postdoctoral resident and I was lucky enough to be offered a position. And I was actually exposed to the OCD world with my introduction at NBI because prior to that, I didn't have any formal training in OCD. So here I am as part of the NBI team.
Hey guys, I'm Katja Moritz, licensed psychologist, and I'm actually, like I said, I'm talking to you from Rio. We have an office here. We did a great presentation this week here for a group of educators and clinicians. So it's nice to be with you. There are about 12 or 13 people that register. We sometimes get a little delayed because of lunchtime. But if we should get started, if not, we can send them the information. Go ahead, John.
Hi, I'm John Hoffman. I'm also a licensed psychologist. I'm not. I think of Florida as exotic because I'm from New York, but I'm in Western Florida, which is not that exotic compared to Rio. So it's nice to obviously speak about the topics that we're also concerned with.
Heidi, do you want to introduce yourself? Because maybe Ilana and you don't know each other. Ilana mentioned also she can introduce
Sure.
herself further.
Thank you. Well, it's nice to meet every day. I met John on Monday, and everybody else is new. And hi, Alana. And I've been researching Shepard Pratt also, and kind of everything on this case I'm working on. Hi, Wilfredo. So I'm an educational consultant for about 20 years, about 15 of which is therapeutic. So I went back and got my master's in clinical mental health about that time ago. So I could support the work I'm doing with a professional training. So, yeah. So I'm new to NBI, although I've heard about it forever. Decided I better get down and see it just because I have a client right now with who has autism, OCD, and body dysmorphic disorder, and he's up at Mountain Valley, and we're looking for a next some more intensive treatment for him. And so that's my background. And I live in New Orleans, which is sort of exotic too. So
Yeah, absolutely.
And spicy.
very,
The
and it's
food is
hot.
spicy
Yes.
and
Although
hot.
it was hot in Weston on Monday too. So
Yeah, we get heat. Yeah. Ilana, do you want to tell us a little bit more about you as we get to know each other?
Sure, yeah. So I'm a psychiatrist here at Shepherd Pratt, and I do a lot of OCD specialized work. And because it's a residential setting, people tend to have a lot of comorbidities, depression, trauma, things like that. So a lot of the people I'm working with have OCD and then something else, and suicidality comes up a lot. So I was really interested in this.
So you work at the retreat?
Yeah.
Yeah. So I know we know John very well. So
Yeah, he sent out this to our group, and so
okay,
that's
great.
how I got connected.
Right. Everyone in this field is named John, who's male, except
Yeah,
yeah.
there was the
There's a lot of
talk
John.
at one of the IOCD
Yeah,
apps.
I did that with
Oh, that you were there.
that's our talk with
Okay,
John Grayson, John
I was far in
Abramowitz,
the back,
myself,
so
and
that's why I didn't
yeah,
recognize you.
right.
Great.
So we should get started, because I don't. There was a long list of people, but as Katja said, who knows? But we'll just proceed, and we record this and send it out to anyone who signed up.
Okay, so let's start with the presentation then, and then we will open this for further discussion and questions that you all might have. So as you can see, today's presentation is going to focus on the context of suicide risk within the frame of obsessive compulsive disorder. And maybe there might be certain type of information that might be new for each one of you, but we are going to try to provide like a clear explanation in order for us to be able to communicate exactly based on our own experiences with our patients, the things that we have been seeing, observing, and doing as part of the clinical work that we do for this type of presentation. Some of the goals that we have in mind is for you both to be able to recognize the differences between what potentially a suicidal obsession might look like versus like a suicidal ideation, and most importantly, what type of behaviors might follow in response to one or the other, which is something that we actually tend to target a lot in this treatment process. And then hopefully you walk from here with a new perspective in terms of what treatment approaches are more recently incorporated in our treatment process, and also what is more empirically validated in terms of dealing with suicide risk management at the present time. So I would like to start with something that I tend to hear a lot, not only from the clinical standpoint, but from the general public as well. And it's this perception that individuals with diagnosis of obsessive compulsive disorder are protected from suicide. And maybe that is coming from this idea of, regularly speaking, someone with an obsession out of harm, right? Harm coming to self might act in a very avoidant manner. You might see people like walking away or running away from certain things, no? And that might be shaping that perception. In other cases, you might see people think, oh, people with OCD might have like difficult doubting, and they might not be even able to decide when and how they're going to end their lives, right? And they might actually believe that having OCD is just merely like a protective factor, but we know for sure that that's not the case. Even research suggests that 1 out of 4 individuals with OCD have attempted suicide, and in average is 1 out of 7. So that is very telling that this is not factual. Indeed, we need to take in consideration what else is contributing with this type of suicidal presentations in those individuals with OCD. So things that we are going to be looking at has to do with certain presentations that tend to be almost always closer to the presentation with OCD, and also some complexities within the context of OCD symptomatology and other diagnoses that might present altogether. So as a shortcut, we might have this differentiation between obsessions within the context of OCD is not equal intent, but when still things started getting complicated with feelings of hopelessness or other comorbid diagnosis, then things are getting complicated and the risk might be a little higher in that domain. Now, in terms of what suicidal OCD is, that's basically a suicide form of obsession that the person is presenting. To put it in context, no, in the context of OCD, there might be different obsessions or themes within the context of obsessions. And we have like what we know as harm-related OCD, and that might present in 2 ways. Harm coming to self and harm coming to others, no? And the person with a form of OCD that is like, oh, what if I'm going to kill myself? What if I accidentally harm myself to the point that I die? Or what if I'm wishing to actually kill myself? Might position the person within this context of what we know as a or suicidal obsession, right? And regularly speaking, this type of suicidal obsessions are followed by certain patterns of behaviors that we classify as an avoidant behavior or plain visibly like a compulsion. We might see people engaging in reassurance seeking, checking behaviors, and so forth, which actually make the process of obsessive compulsive disorder for them and the symptomatology worse whenever they are actually acting in that domain. So that's one point of differentiation in here in terms of in someone with OCD, we know that the obsession, which is one of the part of the symptomatology, is something that the person doesn't connect with his values, the view that they have about themselves, is not connected with the content of the thought. However, they fall into this trap that we know as thought action fusion as one of the thought thinking patterns that influence OCD, in which the person might feel that because they're having the thought, that means that they are actually becoming the content of the thought, or the more chance that the more they have the thought, that increases the chances for the person to act on whatever thought the person is actually having. So in at first stage, this is basically a way for us to understand the concept of suicidal obsessions, no, within the context of harm OCD, and the patterns of behaviors that follow in presence of the distress associated with that initial internal experience that they are having. Now, when we start like comparing suicidal obsession with an actual suicidal ideation, and I decided to put that on top so you can actually have a quick reference to look the main differences between one and the other. The person with suicide ideation actually is having like a desire to end their life, or to end the pain that they are experiencing at a given time, or to escape from a problem that they are experiencing that they are unable to actually find a solution. And this type of desire is molded by certain emotional states that we see in patients who are presenting with suicidal ideation and even intention, which has to do with a sense of hopelessness and significant presentation of depression that might actually put them in a vulnerable position for them to contemplate more strongly that element of ending their life through suicide. Now, what we do when we are dealing with both presentations, and this is something that we see in most of our patients at some point in time. We know for sure that dealing with OCD symptoms, which is a chronic condition, is perceived by patients as this is a long-lasting process, this is tedious, oh my God. And there might be those spikes in the treatment process that might put the person in that hopeless state, no? Because of normal treatment fatigue that they might experience here and there whenever the symptoms are going into a peak, no? And progressively, someone who present with like a form of suicidal OCD presentation or obsession, no? That is very clear that the person was endorsing some fears around, for example, knives or things that the person was actually being triggered by the person progressively when they start like actually struggling with the present of the thought, or the inability for them to fully function or to engage in activities of daily living or participate with family, that is going to start like putting them into this process of feeling helpless and hopeless, and oh my God, why bother continuing doing this if things are not going to change? And then that is when we start like noticing the first signs that things might be shifting a little bit towards that ideation that is more into the grounds of a true suicide consideration. Therefore, our position there is for us to understand what is next, right? And how we can actually protect the patient that is presenting with this type of presentation at that point in time. And that's something that we're going to see later in the presentation in terms of what to do and how to do it, and the reasons why it might be important for us to take that steps, or those treatment steps in consideration. Now, some of the things that we have observed that might increase some level of risk from some of the patients that we have had historically has to do with these comorbidities, right? Oftentimes we have people with OCD, and then they also have the body dysmorphic disorder as a comorbid disorder there. And we know that BDD presents with high rates of suicidal ideation and even attempts. Um, and in addition to that, there might be certain presentations within the context of BDD that the person might be engaging in some sort of self-harming behaviors out of self-harming, not with intention to kill themselves, but with the intention to maybe punish themselves for the defect that they think they are having in terms of the image, or for them to fix for the perceived defect in the body image that they are having. So it could be one or the other. They feel so that they can't stand themselves, or that they need to punish themselves, that they may engage in that type of behavior. Or it could be the opposite. They are so distressed about the appearance of body part that they might try to fix it themselves, and that might actually increase the chances for them to engage in that harm to themselves, but not with the intention to kill themselves. But things could actually go into South Park if they start like engaging very often in those type of behaviors. So again, some of the thought patterns that they might actually have is the distorted self-image, and then how they perceive themselves is like a direct blow to their concept of self, and that increases the chances for the person to isolate and further have like a negative perception about themselves, the future, and others, and that put them in a vulnerable position. The same is true with perfectionism. People with perfectionism, they tend to be very critical of themselves. They might set high expectations of themselves. And also, that might be accompanied with rigid thinking patterns, all of nothing. If it's this, if it's not this, then this. And it is easy for someone with this trait to position themselves as a failure, right? And that is very triggering for them, because they might end up experiencing feelings of shame and embarrassment, which then result in them potential increase in suicidal ideations, not wanting to exist, or yeah, that public shame that they might experience at certain times because of holding achievement as part of who they identify with as an individual. Then we have mood disorders, particularly bipolar disorder is something that we take into account, specifically those shifts in which the person might be more impulsive, acting impulsively and reckless, no, out of the manic processes. And then when the person is going down, tend to increase the vulnerabilities in this type of sectors in combination with OCD. Then personality disorders, what we tend to pay attention in here are aspects of impulsive behaviors when the person with personality disorder is engaging in impulsivity, and also when they are having some difficulties at the interpersonal level, how that could actually trigger like a crisis mode on some of them. So those are factors that we take in consideration in order for us to provide some input of what strategies to use therapeutically speaking to reduce those vulnerabilities at a given time. Then we have autism, and with autism, we know that these individuals tend to present with difficulties with sudden changes, very rigid. And oftentimes, when things start happening around sudden changes, they might feel lacking some level of control, and that might increase some aspects of hopelessness, which also increase those patterns of behaviors that follow whenever they find themselves not knowing what else to do and in that low mood position. Now, in terms of suicide risk factors in OCD, as I suggested before, when an individual is going through a long course of treatment or a long course of process with OCD, and they find themselves like struggling with long-lasting compulsions, or the families are actually being pulled into a process of compulsions, they might end up getting into a heightened level of distress and emotional turmoil, to the point that the person might start like feeling like emotionally exhausted, and start my experiencing like feelings or even thoughts that I might be a burden to my family. It might be better for me to basically stop doing this. So if the person starts like shifting from that position of I have been trying therapy for a while and medication for a while, and nothing seems to help. I just want it to stop, then we are actually seeing like an increase in that component of the physiological exhaustion through management of their own symptoms getting in the way, which is increasing that risk factor of them having like a more suicidal ideation and potentially contemplation of a suicide as a way to end for the perceived shortcomings there. Then comorbid depression. By comorbid depression, we are seeing here a natural tendency for someone with depression to have high vulnerabilities for feelings of hopelessness. And that's something that increases the chances for someone to have those moments, no, of hopelessness here and there, and then followed by suicidal ideation and maybe some behaviors that might be present there. Then anxiety. With anxiety, I have seen patients who they present with a low intolerance for the physiological sensations that is accompanied by the distress and the anxiety, and they feel so overwhelmed by not only the anticipation that I'm going to feel this, but also when they are in that moment, they tend to project that experience that this is going to be my constant in life. I won't be able to escape from this internal uncomfortable experience. I want an escape that actually creates some vulnerabilities for someone to be more into that position of, oh my God, I want to end this. I can't stand this. I'm sick of this. Then suicidal ideation might be more present in those presentations. Trauma history. We know for sure that people with trauma history tend to present with a negative view about how unsafe the environment is and others are, no? And they also present with a high level of physiological activation whenever they are in distress with long-lasting emotional experiences and also long in duration in terms for them to go to baseline whenever they get triggered by one of the natural triggers. I click in here by mistake. And then all of this might end up increasing some functional impairment, isolation, and aspect of stigma, which is going to increase aspect of hopelessness. And then poor treatment response or lack of access to care could also maintain that hopelessness going in that domain. Now, something to outside of the comorbidities, no, and these complicating factors mediated by other diagnoses. Within the context of OCD, we have different themes, no? As I mentioned before, during the first couple of slides, suicidal obsessions are within the context of harm OCD. So we are going to have other set of obsessions that are equally triggering for the individuals, and they tend to cause like this immediate sense of guilt, shame, embarrassment, the thought of, oh my God, how an evil person I am because I'm having this thought, or what a bad person am I because suddenly I ended up having this image, no? So those are things that because it's going to cause like an immediate response of feelings of shame, guilt, and this strong response to avoid and isolate that is going to put the individual in a higher level of risk, no? For example, as you are able to see over there, like taboo obsessions could be from sexually mediated obsessions, like having like a thought about having sex with a daughter or a parent, or the pedophilia theme one, no? Or in scrupulosity, when the person is actually evaluating each single behavior as immoral, and then they start like actually embracing that they are immoral because of what they are actually perceiving themselves and the doubts associated with it. So definitely that is going to actually be like a direct impact to how they are perceiving themselves, and that judgment that they're having about themselves is going to gradually increase, like that guilt, shame, and it could put the person in a strong vulnerable position for suicide to even occur. And with isolation and engagement in avoidance and compulsions, right? There's going to be like that direct impact in their activity of daily living, functioning, in which things are going to be perceived as I'm not functioning, what bother? Therefore, the risk is going to increase. Now, before I jump into the assessment approach, any questions, any comments, Dr. Moritz, Dr. Hoffman, any comments, any input that you would like to provide before moving into this second direction?
Yeah, I mean, I like the concept of thinking of the impulsive compulsive spectrum within OCD and comorbidities, and how that is not really talked about in terms of increase of risk. Because I do think that for those guys who are impulsive and compulsive and have a lot of stigma, a lot of perfectionism, stigma about being sick, and then they have the thought action fusion where they think their thoughts reflect who they are. You could see how that could become a perfect storm. You know, I think that's very important for us to recognize, because people don't talk a lot about that in the general sense, but I think that that's a really important factor that we understand that there is a connection there, and actually looking at those recipe for disaster in a way, right? Like, what are the variables that we have to be very watchful for? I think that's really important for us to address. Yeah.
Yeah, and I think it's interesting with OCD that it kind of only lives in its own little world of logic. Like, you would think someone who's afraid of harming themselves would be afraid of suicide. If they're afraid of some, contamination, that, wow, what a bigger thing to kill yourself. But these one of the interesting things about OCD is everything is very in isolation. That the logic on the left side and the logic on the right side of the street, so to speak, have nothing to do with each other. And that's one of the clinical nuances that I think is so important to keep in mind with this population.
Something else that I forgot to mention in the context of OCD as well has to do with contamination concerns. And some of the patients that we have had historically might put themselves in a very vulnerable position in a medical risk that maybe they are not intentionally trying to end their life through suicide, but it could cause for their systems to shut down to the point of that resulting in death. And that has to do with contamination concerns whenever the person is afraid of eating certain food products or drinking, hydrating. And yeah, we have had those cases in which we needed to proceed with some level of medical checkup, no? Or some sort of hospitalizations in order for us to make sure that what was needed at the time or was taking precedent at the time was taken care of, in order then for us to proceed with whatever protocol we were implementing with the patient that came up to us at the first time. Okay. So let's move then a little bit about the assessment process. Whenever we are actually identifying whether this person is at risk or it's just an obsession, we can manage it simply with a OCD type of ERP protocol versus we might need to hold a little bit of this treatment process with ERP, and we might need to do a little more of crisis management planning, no? Or we might need to stop and provide some emotional regulation and distress tolerance skills here and there. It will make the difference in terms of the course of protecting the patient and what to address and how to address it in the treatment part. So as you can see in this slide, these are general steps that we tend to take, no? On how to assess for risk. And it could be something as not as structured as you are seeing in the first block, or you can actually use like some structure measures, but in general terms, we are looking for specific aspects or information to identify whether or not the person is actually in risk. And some of the things that we were looking for is the suicidal intention, no, outside of the thoughts. If the person is actually intending, if the person is actually having the plan or access to mean, we are actually trying to look the quality at times of the thoughts, and then how is it that that person is mobilizing himself or herself in the presence of that internal experience. So some of the thoughts that might be less linear or less visible, because we know there are certain patients that they may present, oh, I want to kill myself, I'm tired and sick about this, but there might be other individuals that they might say something that for the not expert ear might sound like, oh, this is just like a complaint, or just this or just that, and like not taking step in further assessing what is influencing that response in the patient could actually make a difference. So things that we pay attention to is like a hopeless tone in certain verbalizations. For example, when someone is saying nothing will ever get better, or there's no point in trying, that is something that we should pay attention to, no? The other aspect is when the person is perceiving himself or herself as a like a burden to someone else. Like, my family will be much better off without me, or I'm just causing problems, no? That could also be signaling of, hey, I need to close attention if there's like a sudden shift in his mood or her mood, or if there's like some other signals that the person is isolating, less participative in treatment, more hopeless, more ruminative. So those are things that we take in consideration. As I mentioned before, obsessions that might trigger feelings of shame and self-hatred in the context of BDD, no? I'm disgusting, I don't deserve for care or for forgiveness or to be loved, could also be indicative of that quality in the way the person might be experiencing themselves at a point in time, when the person is presenting with thoughts just as no one understands me, no one wants to be around me, or feeling trapped. No, I'm feeling stuck with this. I don't know how to solve this. I don't know what else to do. Those are things that we pay close attention. In addition, of course, to the intention to act on whatever plan they are actually foreseeing, or if the person is actually access to me. Now, a big component also has to do with risks factors. And in terms of risk factors, we actually take in consideration previous suicidal behaviors, attempts, hospitalizations, history on that one, um, even the complete diagnostic presentation, if they are having the diagnosis that we were mentioning before, that increases the complexity, like bipolar disorder, mood disorder, and so forth. And if the person is actually experiencing at the time of the endorsement of the suicidal ideation and intention any key symptoms like impulsivity, interrupted sleep, anhedonia. So all those type of things, including family history, if the person is under the influence or a substance user. So those are factors that we actually take it as a like a scan type of thing in order for us to actually identify whether or not the person might be falling into a more high risk level, than just simply a person who is having like a harm related OCD obsession, and just simply that, no?
Yeah, I want to mention something. I think Heidi, Ilana had to go because she said she had a 12:30 patient. But one thing that I think is important for us to address is that, for many, many years, like we kind of lived in this limbo of like OCD specialists because we don't use our, mandate to protect at times because it's OCD, right? So right now we have a patient at the clinic and he may think that he harmed someone, but he never met this person. And he goes and confesses and goes to the police station and tells them he did it, right? And usually if a patient says to us, I harmed someone or I'm going to kill someone, we have the duty to protect, right? And it's a funny thing because for a long time I've been presenting on this, which is, wait, so we don't have any protections with the law that a patient that has OCD and is saying those things, we usually ignore it or even make fun of it in the sense of exposures, right? So for them to say, oh yeah, I killed this person, yes, so they do an exposure session. But the reality is that we don't have protection. So if a patient says, I'm afraid I'm going to kill myself, right? And they're like checking and saying, I'm afraid. And we do nothing. We don't hospitalize them. We are taking upon ourselves the chance of the risk. But also, we know that if we do hospitalize a patient who is actually not even less likely to kill themselves than we are, because they not only are not suicidal, they are so scared of suicide that they will make sure to protect themselves. We can also harm them by actually sending them to the hospital. So it's kind of like a funny feeling because how many times have I taken a picture of a patient with pills all over them, pretending that they did kill themselves as an exposure because that was the fear. But that was never going to happen because they wouldn't even be close to medicine because they were so afraid of that, you know? So it's kind of a funny feeling. And I think that, we all have to walk this journey carefully because the process of understanding what is ethical and what's legal is interesting. Because if I will go in front of a judge and the parents said, oh, you never did anything to protect my child, because I missed it, right? It's just because I was biased against the OCD. So I think that we have to be even more careful about the bias because we have to be even more aware that don't listen to your bias just because it's OCD, but make sure that you go through your due process in a very thorough way, because if you do make a mistake here, reinforcing the fear of we had patients that the police was called on them because the clinician called the police because they had said they were afraid they're going to harm their child, right? And we know the impact, I mean, the trauma for everyone, but the impact of that on the treatment and on them. So it's an interesting point to think about the protective factors for the patient, but for all of us as clinicians, right? How do we protect ourselves when we have to make a judgment call? Is it 100% bulletproof? Luckily, we haven't had someone like clearly OCD without any risk really try to do anything to themselves, but who knows, right? People, I don't know, people can have a moment and do something. So I think it's always important for us as consultants and clinicians like yourselves. We need to think about, all right, how do I do this and protect the patient, myself, the family, and the process, right?
Can I ask a question? Is that okay?
Oh yeah, I think we could, yeah, absolutely go through the quite anytime. Stop us anytime.
So I guess for all of you then, what type of supervision do you do then or bring it to your group? I'm thinking the safety there as the team is that you go to each other with a case like that. So can you tell me what you do at MBI in that kind of really complex situation you describe? I appreciate
Well,
hearing.
we do two things. One, you're right, we have a team and we have a risk assessment team. Dr. Rivera is very prominent on our assessment team. But one of the things that we've even done is we've tried to really have continuing education. We're just at ongoing. I think we're in session 5 of training on the cutting edge suicide prevention techniques and looking at suicide modes and how to actually use these protocols most effectively. And as Katya was saying, for so many years, the book on OCD was suicide rates was very, very small. It's only in recent years there's been research saying, hey, that's not true. So we've had to really, people who were trained many years ago have really had to change our thinking about this. But NBI, that's one of the advantages I think of our kind of approach is that we're always trying to stay on top of the literature, having consultants on different things, and always
Yeah.
trying to say, well, a lot of the things you believe, one year turned out to be totally not true with new research.
Right. I think
So
it's
we really try to stay.
actually, yeah. I think sometimes, and I see here in Brazil more than anywhere else, because it's very psychoanalytic, right? Brazil is a very psychoanalytic country, is where things froze many, many years ago. The same theory that Freud talked about is what people are practicing today. So I think that for us is the opposite. We want to shake it up every time. I think also as a team, it's interesting. So we actually keep our patient number very low and our communication time and training time very high. So if you think about it, we spend much, much more time sitting and talking and reviewing the cases than we spend with the case directly, which is a weird platform. I don't think people like that very much. They're driving based on the business, but we feel like that really protects us. So for instance, the team meets 5 hours a week, every week, in a steady schedule. Then they meet another half hour every day on top of that at 2:30 for our review of the day. At 9 o'clock, we have a touch point in the morning, and then not only have like Dr. Dr. Rivera is saying, he's been doing this for over 10 years. John and I've been doing this over 35 years, and John, even more than I have been doing, probably more like 40 some years, right? And we still have David Tolan from the outside, 60 hours a week to come in and say, do I like what you guys are doing? Are we really doing top-notch work? So we keep kind of like doing consults on the outside to evaluate our own performance with that. And if you look at the core values of NBI, safety first is our core value, right? So our first value is safety first. And it's really hard because I think that that's the idea, is that how do we, safety means sometimes not being so safe, right? Meaning taking a risk and helping a person. And I think that that's where we kind of try to walk the funny line of, we say safety first, but then someone brings us a hardcore, difficult case, and we're the first to get excited about, which is, well, it's hard for us because safety for us is a question, at that time. I mean, I've been hit a few times, and actually a patient from Brazil hit me pretty much badly because the mom didn't tell the kid love to hit clinicians. So I got hit, right?
And it's and it's kind of always a tension between little s safety, the safety of the moment, and big F safety when you really address a case comprehensively. And we're always trying to weigh both of those kinds of things. If that answers, Heidi, if that answers.
I really appreciate this. Makes, not only do I understand what you're talking about, it's also in my experience, it's how I am oriented as well. So,
Right.
I will, certain cases that might look on the surface or recommendation might be somebody needs a locked facility, and sometimes I think that's the that's the unsafest
The unsafe.
safest
Right,
thing
right,
to do is to put them
right.
in a setting that is actually going to be able to work with them.
Right, right. And as what we do get sometimes is people like, you can't be scared of doing what you know to do well, just because liability is always there for everything. You have to be conscious and deliberate and mindful of what you're doing.
And
So I think,
communicate it effectively that
communicate, yeah.
everybody understands the pros and cons.
Yeah.
So is that communication equal communicating effectively then with the loved ones of the
Loved
patient,
ones,
Yeah.
everyone.
the
One of the
family,
things,
so
Heidi,
that
we
they
do.
understand what you're doing?
That's one of the reasons we try whenever possible to engage the families in the treatment. We have an intensive parenting program, family programs. So when we take on a case, we do have not a high census anymore these days because, as I mentioned to you, we changed our philosophy of what we're doing. But we have a very deep uh, attempt at collaborating with each of our cases. They're seen many, many times a week, even though we meet a lot. The people who are working, they're getting maybe 20, 25 hours of real clinical time a week plus activities, and engage their families with regular communication and engage the collateral people on who know them and
Right.
working
So,
with them.
yeah. So one thing that, like we did before we kind of restructure and got into a smaller group, but a much deeper work with that each individual, is that learning what our biases could be. Like sometimes people don't want to listen to work that was done before, but why shouldn't you? Why shouldn't you hear from another professional what worked, what didn't work, right? Almost like, it's important to get your fresh view of a case, but also learn from others' experiences. I always tell parents, I don't care how difficult the parent is, you know your child better than anyone. We may know the treatment better. Maybe we understand the treatment better, but you know your child's response. And even for the sickest of the parents, you can actually weave the illness and the knowledge, right? You can realize some things are sick or not part of what you want to put part of it, but the other part is what they are able to really tell us about the case and the people. So our patients are, if they don't do parent and family, we are very likely to tell them that we are afraid the treatment is not going to work or it's not going to be long lasting, because we are temporary in your life and your family is likely to be long term. And the families don't.
You can hear.
Katia, you was cutting out a little bit. We can't hear you, Katia.
So can you hear me now?
Yes, we can hear you now.
Sorry. Yeah. So if we don't help the families change their philosophy, then we didn't do a good job. I mean, we need to really work with that core understanding of how to move forward with the families. So we do spend an egregious amount of hours with that, like where we actually call them, we update them, and because I think it's a shared risk, we need to talk about what are we're trying to do together. So I think it actually that partnership has to be very well established from the get-go, and we tell the parents that they are part of the team, they are part of the clinical team moving forward. They have to be giving us the feedback. They're not there to audit what we do, they're there to help us do better and bring things up as we go. And I think that makes it a better relationship and a better outcome.
Anyone else has any other question, comments? Okay. Now, in terms of protective factors, that's something that we also take in consideration, no? And as it was suggested, we try to involve family to be part of the processes that we follow with our patients there. But most recently, we have been incorporating um, like a more clear system on how to deal with individuals who are having high risk presentations. And the format that we are incorporating in our treatment process has to do with what I'm going to show in here in this slide. We are incorporating what we call crisis planning and commitment to treatment. These are two things that we are seeking for the patient who is presenting with suicidal ideation to abstain for certain specific behaviors while the person is participating in treatment, no, with us for a specific period of time, right? And in addition to that, while the person is in that process, we might end up going into this protocol for them to be able to identify triggers, internal, external triggers like thoughts, thinking patterns, feelings, urges, patterns of behaviors that increases the chances for a crisis to occur, right? And by intervening and seeing the process of suicide crisis, no, as a suicide episode, no, seeing like it has like a started point and an end point. Whenever the person is experiencing that crisis, we are able to, like help when the person is safe and no longer in the crisis that the person was experiencing, no, through assessment of the triggers that cause for the person to get admitted to a hospital, right? I'm talking about after hospitalization. We have a patient that started our program after being stabilized, right? And then we are dealing with the patient, and now we are identifying, okay, so what things cause for that person to dysregulate to that level, and then to actually be able to dissect it in order for us to provide the actual skill that the person need in that crisis plan that we call, right? In which we identify the specific coping mechanism, the specific people for them to reach out, which is a skill that they put also in practice and so forth, is going to actually increase the chances for the patient navigate like the crisis in a more safe manner. So that's basically the approaches that we are actually following in here, with specific steps and that, yeah.
Yeah, well, can I mention something? I think
Sure.
like well, we could talk about experience, like so many years, guys, doing this, that we had gone through iterations of safety. And it's interesting because in the past, one iteration was to make people sign a contract that they weren't going to kill themselves, right? So we felt like really good about that. All right, if you sign this contract, it's safe. And then it was recognized that that really didn't really increase much safety, and that commitment to therapy, commitment to treatment, having a plan of treatment actually made people commit to staying around. So if you say, you know, would you commit to in the next 6 months focusing on treatment and not killing yourself? Change the commitment base of that statement. But also, I think what Dr. Rivera, you're saying that is really meaningful and important is that we did zoom out from the suicide as a action, but actually as a crisis. And so I like the concept a lot because all of a sudden you operationalize what suicide means, and you actually look at the variables as just variables. You take the emotionality of like someone is going to kill themselves, which we change that to someone is going to die by suicide, which now there is a crisis that leads to a behavior. And now we are taking down that variable, separating that variable, so people, as they are experiencing them, they could actually step out, zoom out, and say, I see myself now thinking this way. I see myself planning this, and that space allows them to take an action. And I think that that's really one of the real big steps that we've taken in the cognitive intervention of suicide, in a way, because it becomes a behavioral change. So as you do that, your behavior can change. And I think that for all of us, the consultants, the clinicians, learning to actually help the person zoom out and say, what are the behaviors? Like what was happening before? Antecedents, behavior, consequences, right? How people manage allows us to also treat suicide threats as part of like a secondary gain and reinforcement and avoidance. Because then we realize that for some people, there is a thought, there is an action, but the consequence is actually to get out of whatever they don't want to do, or to get people to engage with them. That doesn't mean that we're not going to address it. We're going to take all the same measures, but we understand the function of the behavior so we could change that behavior. So looking at that is interesting, but also it separates out the reinforcement of the OCD in case someone has both. If you have suicidal ideation and fear of harm, right, you are able to kind of realize that your thoughts are not going to lead to actions alone. But if you actually go ahead and purchase a gun to have in your house, that becomes a step, right? So being able to learn the differences between feelings, thoughts, and actions instead of joining all together becomes a very good tool for addressing patients that we are addressing.
Mhm.
Well, we have only 3 more minutes. Should we open to we have Alexandra and Celia here. So if with Heidi, if you guys wanted to ask any questions, is there any specific thing, or even shoot us some ideas for the NBI clinicals? We really are enjoying doing this presentations and hoping that, you know, it benefits our community. And so if you guys have any topics or ideas, for the team, we have guests that we invite. We can have anything. So just if you guys want to shoot us some ideas, it would be amazing.